platform of Orthopedic Research and Education Foundation of India. Today we have Dr. Arvind Prasad Gupta sir, who is a consultant and sports medicine specialist in Paras HMRI Hospital, Patna. So he's teaching us about reverse shoulder arthroplasty. He's simplifying the techniques and other things about that, the recent advances and all. So over to you, sir.
Thank you, Janki. So let me start with share the screen. Can you see the screen, Janki?
Yes, sir. Perfect, sir.
So, today topic is reverse shoulder arthroplasty. So, in the reverse shoulder arthroplasty, the glenoid become convex and the humeral head become concave. That is opposite to the normal anatomy. That is the normal total shoulder arthroplasty in which the glenoid is concave and the humeral head is convex. But in reverse shoulder arthroplasty, the glenoid become convex and the humeral head become concave. So why the need of this surgery nowadays for shoulder problem? So we'll discuss about that, how this get evolved, what are the indication, what are the complications of this surgery. So we all know shoulder joint is very mobile joint in which because of the articulation of the humeral head and the glenoid, in which the humeral head hardly 20 to 30% get in contact with the glenoid, and because of this joint is hypermobile joint. At the same time, because of the high mobility, the instability also comes, and that get fairly accommodated with the help of the labrum, capsule, ligament, and the muscle, particularly the rotator cuff and deltoid, that all work around the shoulder joint. So if you see in the rotator cuff, the supraspinatus, first thing, it stabilizes the center of the humeral head against the glenoid, particularly in the early stage of abduction, when there is fulcrum of the deltoid muscle is there, which try to pull the humeral head up, but the supraspinatus keep it down in the glenoid cavity. The next is the infraspinatus and teres minor. This help in passing the greater tuberosity inside the acromial arch in the mid-range of abduction and the external rotation of the shoulder joint. And we can see here in the coronal section as well as in the axial section how all these four rotator cuff muscle stabilizes the humeral head against the glenoid. In the superiorly, there is supraspinatus that keep the humeral head down inside the glenoid cavity. Posteriorly, there is infraspinatus and teres minor. Anteriorly, there is subscap. So all these four muscles act together to hold the humeral head inside the glenoid cavity and make it a stable joint. And along with deltoid and the rotator cuff, there is other muscle also that work around the shoulder joint that help in ease mobility of the shoulder joint. And this deltoid, this having the fulcrum, the superiorly. So with the abduction, this humeral head try to goes up. So this gives the instability to the shoulder joint. But because of the supraspinatus, it's keep in the shoulder joint. And once supraspinatus is torn, this humeral head keep going up, that rub against the undersurface of the acromion at the same time with the glenoid also. So that leads to development of the glenohumeral arthritis as well as acromiohumeral arthritis, because of there is no cuff in between humeral head and the acromion. That leads to development of rotator cuff arthropathy. So here you can see this is extreme left is the normal shoulder joint where the shoulder humeral head is staying into the joint. In the rotator cuff tear, humeral head start going up, so center of rotation going up. And in the reverse shoulder, we keep the center of rotation down and medial, so that this deltoid muscle act as a abductor, and because of the medialized joint, it's become a stable one. So this is the principle of reverse shoulder orthoplasty, which was first designed by the Charles Neal. But there was limitation of this design because of the fairly constrained. There was high chances of the glenoid component loosening, at the same time implant breakage, and also there was lateralization of the center of the rotation. So in 1985, the Paul Gromand came with the novel concept of the ball and socket design, that based on the four principles that started with the shifting the center of rotation from lateral to the medial. Here we can see here. So this is the shoulder joint. So this, if you see, almost the center of rotation somewhere like there normally. But in case of the reverse shoulder, this goes there. So this much of the shifting of center of rotation from the lateral side to the medial side. How this helps shifting? This decreases the moment torque, mechanical torque over the glenoid base plate. So the glenoid loosening become less. The second principle was to keep the humeral head lower from where it is. So this lowering leads to tension the deltoid muscle, and this increases the muscle fiber firing, both anterior as well as posterior. So all the deltoid act as a abductor of the humeral head. So this compensates for the deficiency of your rotator cuff. Next is the third principle, the center of rotation become medial and the distal. So this medialized and distalized center of rotation gives the stable implant. So joint become very much stable than the natural joint. And also this distalization and medialization says there was 42% increase in the deltoid moment arm. So this gives the power to deltoid to act as a abductor throughout the range of the motion of the shoulder joint in case of reverse shoulder orthoplasty. The fourth principle was the glenosphere. Glenosphere, the implant that resides over the glenoid part, is the large glenosphere. So because of the large glenosphere, this gives the high range of motion, almost up to 110 degree around the shoulder joint. So all these four principles was given by the Gromand reverse shoulder orthoplasty. And if you see the implant wise, so humeral head is usually straight, and the cut of the neck shaft angle was 155. That was high in that time. And over that, there was the inlay humeral liner. And on the glenoid side, there was the glenoid base plate. And over that, there is the glenosphere. That was almost half of a sphere. So this gives the satisfactory elevation. But because of excessive medialization, the price has to be paid in form of the scapular notching. So nowadays, the discussion over the optimal fixation about the implant design, at the same time the positioning of the implant also. So this implant design and the positioning of implant main focus over to decrease the scapular notching as well as reduce the micromotion of the implant. And this start with the placement of the glenoid base plate that should be the flush to the inferior rim of the glenoid. As well as if anything has to be overhang, that should be on the inferior side. And there is little bit glenoid lateralization also. This prevents the again scapular notching. And this glenoid lateralization can be up to 8 to 10 millimeter. And if anything tilting, it should be the inferior, not superior. Even if inferior tilting, again decreases the scapular notching. But only inferior tilting, then you need to do the reaming of the glenoid much more. Then that will not be effective. So inferior tilting should be added with the glenoid lateralization at the same time. And also, of course, the large glenosphere, that is in anything in between 38 to 40, having high survival rate. And the neck shaft angle that was initially 155, now it has 135. People preferred it. So again, this prevents the scapular notching also. And about the placement of the glenoid base plate, even up to 50% of the glenoid base plate support over the bone is good enough. And anything up to 25 degrees of retroversion is acceptable. So about the indication, it starts with the rotator cuff arthropathy that we have seen previously also. There is no cuff in between the humeral head and the glenoid. So because of humeral head and the acromion, so because of the pull of the deltoid, this humeral head keep going up, and so this rub over the under surface of the acromion as well as the glenoid surface. That leads to development of the arthritis, particularly with the massive rotator cuff tear. This happens. And the treatment is reverse shoulder arthroplasty. So this deals with the arthritis component also. At the same time, because of deficiency of the cuff, you need to have abductor also. So this deals with the abduction also, because after reverse shoulder arthroplasty, your deltoid become the abductor of your shoulder joint. Next indication is the pseudo paralysis. What is that? So there is full passive range of motion, but hardly there is active range of motion over the shoulder joint in absence of any neurological injury. That is called as the pseudo paralysis. You can see here, this lady is 62-year female having full passive range of motion, but the active, hardly there is any movement at the shoulder joint. She has to lift or rotate whole of his body for the abduction or any rotation movement. So this is called as the case of, this is a case of pseudoparalysis. There was no neurological injury. The active range of motion was hardly any active range of motion, but passive range of motion was full. And this was because of this was the MRI of this lady. There is complete massive tear of the rotator cuff, as well as the humeral head was migrated up. Here you can see also. And on the axial section, where we assess the muscle bulk of the cuff, here you can see almost this is below this tangent line. So almost more than 50% of the muscle belly was lost. So there was massive fatty infiltration also. So along with the massive rotator cuff, there was grade 4 fatty infiltration in this case also. So this was a case of pseudoparalysis because of all these changes in the cuff. And this was treated with the reverse shoulder arthroplasty. This was after the 2.5 months of follow-up. This was the clinical of this 2.5 months of follow-up. So we can see here, she is abducting her shoulder. So in this case, there is no rotator cuff, but abduction is possible because of the deltoid moment arc that get increases because of the reverse shoulder arthroplasty. And this is after the 4.5 months of this lady. Here you can see there is full abduction, and also she is lifting a little bit of weight also, and she is doing all her activity. So next indication is 3 or 4 part fracture, proximal humerus fracture, particularly the age is more than 70 year, where the reconstruction is almost impossible, or there is head splitting fracture, or poor bone quality, significant osteopenia, or the greater tuberosity has poor potential for the healing. Next indication, when the hemiarthroplasty or total shoulder arthroplasty failed with there was absence of the cuff. So this can be treated with the reverse shoulder arthroplasty. Next indication, when there is arthritis along with the degenerative cuff. So if we have to deal with the two problems, degenerated cuff along with the arthritis. Again, 70-year lady with bilateral shoulder joint arthritis with, you can see there was degenerated cuff in this case was again. So again, this patient was treated with the reverse shoulder orthoplasty, where the center of rotation get medialized and lowered down, so that the deltoid act as a abductor in this case. And also there is rheumatoid arthritis cases, arthritis of the shoulder joint in rheumatoid patient. But in that case, you have to check for the glenoid bone stock, whether it's sufficient or not. If it is sufficient, then this can be treated with the reverse shoulder orthoplasty. There is a lot of contraindication for reverse shoulder orthoplasty also. So starting with the axillary nerve dysfunction, again, you have to differentiate in between temporary and the permanent, because in trauma cases, a couple of cases will have temporary axillary nerve dysfunction, so have to be separated from the permanent. Then there is deltoid deficiency is there. This is the contraindication for reverse shoulder orthoplasty if it is global deficiency. But some people are doing in partial deltoid deficiency there also, and they are showing a good result with the reverse shoulder orthoplasty. When there is acromion deficiency is there, where this deltoid get attached, again this is the contraindication. Then there is glenoid bone post problem in form of osteoporosis, osteopenia is there. Then again, this is a contraindication. On, of course, like any joint, if there is any infection, then this surgery should be contraindication. About the complication, so most common is the scapular notching, and it was almost in 44 to 96% cases of the Gremont type of prosthesis. And this was mainly because of the cut of the humeral head was almost at 155 degrees, because so that this center of rotation should be medialized effectively to get a stable joint, and that leads to a scapular notching. And this incidence get decreases with the lateralization of the base plate over the glenoid. And other risk factor, if this glenoid base plate become placed superiorly or tilted superiorly instead of inferior tilting or inferior placement, then again risk become high, and also a very high medialized center of rotation, and there is increased risk associated with the high BMI also. Then another risk complication is the dislocation. So incidence is almost in between 2 to 3.4%, and usually this is the most common cause of early failure. So then risk factor in dislocation says irreparable subscapularis, that is the strongest risk, because there is no support anteriorly. Again, if there is proximal humeral bone loss, or those having failed hemi or total orthoplasty have high chances of dislocation rate in comparison to reverse shoulder in other cases, and also proximal humerus non-union. Other risk factor is the glenoid loosening. If glenoid loosening is there, or acromial or scapular spine fracture is there, or anything, if there is deep infection, and that is many a time this joint, initially there is hardly any infection, but patient comes with 1 or 2 months of surgery with the deep infection. That is another complication of this reverse shoulder orthoplasty. Thank you.
Sir is there, sir. John sir has joined. So thank you very much, sir. Sir already joined. Maybe he's having some problem there. So while we are waiting for the question, sir, the one thing.
Yeah, I'm back. Sorry.
Yes.
Good evening, sir.
Internet problems here. I'm in Kabini. It's a jungle resort, so In between, the electricity went off, then the internet came, then it just went off for a moment. So anyway, so that was excellent. Heard most of it except the beginning. Couple of things. What are your guides to the proper tilting of the glenosphere?
So glenoid base plate, you have
Base plate,
this jig for the placement over the glenoid. So at least inferior part should be covered with that jig. Jig comes with the different sizes. So whatever the sizes you should place, so inferior 2/3 should be covered with that jig. And there is central hole in that jig. Over that you place your guide wire. So anything, if you have any confusion about whether it's going superior or any dot, so it should be always in the toward the direction should be little bit down, so that it should be the inferior tilting. But jig almost guide you for the placement of the central guide wire.
So that will also guide your tilt, is it?
Yeah, tilt also, as well as
you can have the guide wires via central, but have it tilted up or down, whichever way you want.
Yeah. So as you place, suppose this is the glenoid, and you have placed the jig like this. So you can lift your arm like this also, or this also. So if you lift your arm up, so it means your tilting is superior. And if you lift your arm down, it means tilting is inferior.
Yeah, that's okay. But how do you judge exactly how much to tilt it?
So again, as you place this, suppose this get flush, jig get flush with the glenoid, and you just drill over that. That is the perfect tilting of your glenoid base plate.
So going on with that, is there a role for navigation or robotics in this?
Yeah, nowadays, this particularly for the placement of this glenoid base plate, because the mostly problem comes from the glenoid side.
Yeah.
A lot of center have started doing under navigation with that. Even the pre-op planning with this
PD.
Yeah, again,
PD reconstructions and
PD
printing,
reconstruction with the glenoid is also a lot of center are doing with this.
Yeah.
There is one question asked by Dr. Sachin, is what is the indication if it is head splitting fracture?
So first of all has to be see the physiological age of the patient. What is the physiological age? If very elderly, more than 70 years, head splitting fracture, bone is osteoporotic, looks like it will fail with the osteosynthesis. So patient can be treated with the reverse shoulder arthroplasty. In fact, incidence of reverse shoulder arthroplasty in head splitting fracture in recent year has gone up very high. Sir will give expert comment over that, but in the West or US, the incidence is doing treatment with the reverse shoulder for these type of fracture is very high in elderly people.
Yeah, but I think by and large, you should try and restrict it to the older patients, because in the younger patient, you want to avoid the reverse shoulder arthroplasty because we still do not have very long-term results of them. And over 10 years, the older prostheses have had a problem with deltoid weakening.
Yeah.
So I think the newer generation prostheses with the slight lateralization of the base plate, etc., may have less problems, but we don't know the long-term results of those as yet. So I think try and reserve it for older patients where you know that you cannot reconstruct the shoulder adequately and your fixation is likely to fail. So in those ones, it's better to do a primary reverse than have to do a secondary reverse after failure of your fixation, just like it is for the hemi.
So if it is not, if it is total shoulder arthroplasty, that may be a choice in older patient, or reverse is preferred over total.
I think
if it
total
is
shoulder for trauma has more or less gone out of vogue. Okay. So you either do a hemi in the younger patient where you think the rotator cuffs are still good and you can reconstruct the tuberosities adequately. Or if it's an older patient where you are not able to reconstruct adequately, you would probably go directly to a reverse than worry about a total shoulder arthroplasty. Arvind, what's your take on that?
Yeah, same. If anything can be done, then the hemi or reverse shoulder, not total shoulder for proximal humerus fracture.
But in younger patients, you want to try your best to reconstruct it
Yes.
as far as possible. So primarily, that is your aim. If you have a situation where you can't. So in many of these, you should have the really bad fractures. You should have the option of a hemiarthroplasty. There is also a third option, which is called the just unique, which is where you just replace the head,
Fracture part of it.
just the fractured part of the head, and suture the tuberosities back into place. So that is something which we do not have much experience with, or we don't have any experience of our own with. But the problem is it doesn't work very well in the elderly patient. It works better in the younger patient. Okay.
So if it is reconstructible, so we can do osteosynthesis. If not, then hemi in younger patients.
Or this just unique is an option which
Okay.
is somewhere in between, because you can convert it later into whatever you like.
So one question asked by Dr. Viswajit Prakash, that any surgical landmark to decide the tilt of glenoid, what you was discussing, sir.
So we have just discussed about that.
Yeah.
So first is the jig. First, I start with the shift of the glenoid. It should be flush completely in the inferior part of the glenoid rib. It should not be the above to the inferior part of the glenoid. Then your jig again should be over the flush, or anything tilting, it should be tilted inferior jig. It should not be tilted superiorly. That has to be taken care at the time of making the drill, the central guide wire placement over the glenoid.
And as a corollary to that, the most important thing is to get a good exposure of the glenoid. Okay?
360.
If you have a good exposure of the glenoid, you will end up in problems with your positioning.
So,
see 360 degrees of the glenoid, and that will make it more. It will make it easier for you to position it exactly where you need to.
So Dr. Sachin has asked what role of deltoid lever arm if we do medialize or lateralize the glenoid base plate.
So with the medialization and lateralization, it's the main is the inferior center of rotation. So if you make it inferior, so length of your deltoid get increased. So this become tense. So this act as the full abductor of your shoulder joint. Even the posterior deltoid also and anterior deltoid also, along with the lateral deltoid, become the abductor. Not only the lateral deltoid, anterior and posterior deltoid also become abductor in that case. So it's the main thing is the inferior placement of your center of rotation. So with the reverse shoulder orthoplasty, it become possible to the inferior placement with the glenosphere become large and your concave, this humeral articulating surface. So center of rotation become inferior.
So anyway, when you're doing a reverse shoulder, you are going to medialize the center of rotation of the head. Okay? Because just look at it in mechanical terms. Your center of rotation, when you have your head, is at the center of the head, which is way lateral to the glenoid. When you put a glenosphere on that side, on the glenoid side, then your center of rotation automatically shifts medially. So your lever arm for the deltoid increases. So now in the initial prosthesis, this increase is now thought to have been too much. So you try to reduce that medialization by lateralizing the base plate and the inferior tilt. Okay. So you are still medializing the center of rotation, but not as much as you would do in the traditional reverse shoulder arthroplasty. Okay. Any Arvind, that's okay?
Yeah, absolutely right, sir. So it has started with the extreme medialization. Then there was scapular notching and lot of glenoid loosening was there. So
and also long term, the deltoid fatigues.
Fatigue and
Down the
lot
road.
of weakness of the deltoids was there. So surgeon start doing extreme lateralization, almost 8 to 10 millimeter from whatever the Paul Groman has advised. Then again, there was in between. So almost nowadays 2 to 4 millimeter from the Paul Groman, people are using that center of rotation.
So you're still medializing, but not as much as the original prosthesis.
So, one question is about the rocking horse phenomena, that rocking horse complication and treating options. So it is abnormal phenomena, sir. First thing to understand.
Yeah. So this term I heard first time. So rocking horse phenomena, you mean to say?
Yes, sir.
Okay, I don't know exactly.
Yeah, I think you should explain it.
Sir, it's bit because in complication they have given one thing
I know
like
you've asked this question before in another webinar, so you should answer this.
rocking horse in that one.
Your turn now.
In that one, it was not discussed, sir. Rocking horse in last week.
It has been.
Yeah. So I think it's better if we'll see it once. So the other thing about the notching, sir, what he was explaining, one thing you told that it should be tilted inferiorly. Any other things we can take care while doing the surgery, sir, in the technique?
So the positioning, okay. So if you're too high, then again you'll get notching, okay, whether the tilt or not.
And also first start with the 360-degree exposure. That is very important. And you has always fear of this axillary nerve, but you just place your this glenoid retractor just subperiosteal, so there is hardly any injury to the axillary nerve. So first thing is has to be very careful exposure, removal of your all the labrum, that is very important. And after that you place your jig, look for complete flushing. Even if anything 1 to 2 millimeter down in the inferior side, there is no problem. It should not be up. And second thing is the tilting. And same, all these things has to be maintained, because once after making the first drill, then you drill central peg. So again, while drilling the central peg, you has to be very careful so that your hand should not go like this up. It should be down. And also at the time of placement of the implant, because it's not very fixed type of thing, your guide wire or your drilling. So you can go up and down, but always your this hand should be toward inferior side.
So this notching is also a problem in total shoulder, sir?
No, total shoulder hardly there is a problem with the notching, because it's opposite. The humeral head is round, so hardly your stem and this stem neck will go in touch with this. So this is the anatomic total shoulder. So there is no problem with that. Notching is not a problem.
So in your lecture, you told about the dislocation. Chance of dislocation is more in reverse shoulder. So what we can do to reduce that?
No, there is chance is almost 2 to 3.4%. So reverse shoulder is very inherently stable joint, because it get mesialized and inferior. So chances of dislocation is less in comparison to other hemi or total. So it's stable in comparison to other. So, but even there is dislocation happens. One thing is the weakening of this deltoid. And again, because this tension of this deltoid measurement intraoperatively is a little bit not very objective. It's a subjective thing. So anything, if your deltoid remain lax, then the chances of dislocation again there. Subscap, if you repair it, then it's become very good thing. But in, the literature says if subscap is not repairable, then the chances of dislocation in that case is high. But lot of surgeons don't do repair of the subscap anymore.
what we have seen, sir, that glenwide part is always uncemented, cementless, and this side, sir, may be cemented or uncemented. That both is
So
possible.
on the humeral side, it may be cemented, may be uncemented, whatever you want. Company make both cemented and uncemented.
But glenwide is always cementless.
Glenwide is always it's non-cement for reverse shoulder. For primary shoulder, it's cement.
Because you have to get a peg into the thing, no?
Yeah, peg into the central part of the glenwide so that you have punches become very strong, and two screw, one proximal and one superior and one inferior, at least two screw.
And the rocking horse phenomenon is essentially because you have eccentric loading. So if you don't have central loading of your prosthesis, you will get eventually loosening of the prosthesis. So that's been termed a rocking horse phenomenon, because a rocking horse, the movement is not strictly spherical. It's okay. So that's why they call it the rocking horse phenomenon.
So, one thing which is a little confusing while doing surgery is how to uh, maintain the retroversion. So, just if briefly, if you can explain, because at that time you told the hand position should be like this, and to put the implant.
The retroversion of the head.
Yes, sir. In retroversion of the head, the humeral part.
So lot of company comes with the jig over your trial. So at the time of placing your jig in the humeral head, there is trial 20 degree, 30 degree, 40 degree rod is there, and place your arm in between 20 to 40 degree. So almost anything around 30 degree of retroversion is good enough. Even if it is not there, but in the humeral head trial, that wire is not there, that then you can check with your elbow. So keep the elbow in 30 degree of external rotation, and then your humeral trial is anterior, complete anterior. So this makes almost 30 degree of retroversion of your.
So you look at the transepicondylar axis.
Yeah.
Okay. In neutral position, that will be at 90 degrees. So you internally rotate it 25 degrees. It should be the correct position. Okay.
I think, sir, we have covered most
Yeah.
of the questions, and it was great, sir, to listen.
Thanks very much, everybody. And I'm sorry I joined a bit late, but it was impossible to join any earlier because of the power outage that was here. And until next week. Next week, what is on?
So we'll have that Ganjuwala sir class on CP, cerebral palsy management,
Follow up
and
to the last lecture on CP.
yes, sir, continuation of that.
So until next week, bye everybody.
Yeah. Thank you very much, sir.
Thank you very much, sir.
Bye.
Thank you, sir. Thank you, sir. It is great.
हाँ सर है